Thank you, Laura. So I'm going to speak to one of the working groups making up the See Something, Say Something cluster, which is entitled Youth Red Flags. This working group aims to help us interpret the warning signs of youth radicalization to violence. We know that violent extremism does not manifest in a vacuum, and so frequently following an attack, we discover that somebody knew something, as Laura said. A family member, classmate, neighbor, or friend might have noticed a warning sign of what was to come that they did not know how to contextualize until it was too late. Or maybe they recognized the signs, but they didn't know who to turn to for help. So our work is going to focus on youth demographics specifically to help us figure out how to spot, understand, and respond to these warning signs. In doing this, we're going to be grounding our efforts in an historical context, drawing on lessons from both past successes and past failures to tackle the challenge of youth radicalization to violence. And part of this involves recognizing the complexities involved in efforts like ours. We know that it's not enough to make a checklist of concerning behavior. We know the dangers of mistaking benign youth rebellion, neurodivergence, or behavioral differences as violent threats. And this is why we'll be approaching this topic with nuanced context and sensitivity in order to ensure its success. And lastly, just as violent extremism does not exist in a vacuum, neither does our response to it. So to that end, we will be coordinating with a number of other working groups, namely the Directory and Health Systems, both represented by my co-panelists here, to ensure a continuity of care approach for youth that demonstrate these red flags. Each of our efforts, and indeed each of the efforts of every working group involved in this summit, aims to come together to create a larger mosaic that allows us to approach this problem with a whole of society, multidisciplinary, and comprehensive approach. So if you want to know more about this working group, please join us this afternoon at 2 o'clock in room 301 for our discussion, and I'll hand it off now to Brette.
All right, so my name is Brette. I'm Senior Director of Preventing Targeted Violence at the McCain Institute. In the last year, since the Eradicate Hate Summit, we've taken 2 concrete steps towards our joint effort of building that continuity of care. Last year, on this very stage, I announced the Screen Hate campaign. You can find it at screenhate.org. This is a national campaign launched in partnership with Moonshot, who was on the last panel, specifically for parents and concerned adults to prepare, talk, prevent, and seek help when they're concerned that a youth in their lives may be considering an act of violence. So, following on from Jillian's working group's great work, we launched this campaign, and just in the last year alone, we've had over 1.7 million impressions and nearly 10,000 unique visitors to that Screen Hate site. But I told you, prepare, talk, prevent, seek help. Where do they go to seek help? With the help of Jones Day, One World Strong, and many of you in this room, we built a national directory of resources and clinically licensed providers that are raising their hands saying, we want to be a resource, we want to help when youth may be at risk of committing acts of violence. The resources span all the way from youth resilience, media literacy, and other primary forms of a public health approach to prevention, to next, your bystander training initiatives, your referral systems, your threat assessment, threat management teams, or your intervention teams, all the way through the continuum to recidivism reduction and reintegration. So all of these resources are in the directory, and today we want your help once again. The same working group that Jillian just mentioned, 2 p.m. in room 301, 302, we are having a focus group on that very directory. We want your input. We want your feedback on where to go next over the next year, to identify resources. My dream is every county in the state, just as Vidya mentioned, as well as to really make the app as user-friendly as possible so that it can be a resource for all of you in your work as well. So please join us 2 p.m. in room 301, 302.
All right. Hi, my name is Emma Cardelli. I am a clinical psychologist and research associate at Boston Children's Hospital, Harvard Medical School, and piggybacking off of Brette's commentary on the directory specifically, I think, if and when it is appropriate to refer someone to a mental health professional, it's really, really critical to ensure that that referral actually counts. That providers have the confidence and competence to identify, assess, manage, and/or treat violence risk as part of mental health services. Unfortunately, in my experience, mental health professionals get very little training in graduate school in identifying risk factors for violence, conducting assessments with sensitivity to that violence risk, and in addressing violence risk as a core component of treatment. The emphasis in graduate school is not on working with people who are hard to engage or resistant to services, who say or do things that maybe make you uncomfortable or scared or upset. And this has profound implications for building a mental health workforce that can respond to the needs of individuals at risk of violence. In addition, the healthcare systems in which these professionals work, they also have their own limitations. For example, mental health professionals working in acute or emergency services, they're often asked to focus very, very narrowly, to focus their assessments very, very narrowly on determining whether or not someone needs to be hospitalized right now, not on developing a comprehensive risk management plan, on setting up an array of community-based services that can help prevent an act of violence a month or 2 from now, let's say. And this is why research has shown that most adolescents and adults who present to an emergency room due to concerns for violence end up receiving the majority of their care in the ER. Because where do they go after discharge? Which providers in the community are truly prepared to conduct a more comprehensive assessment of violence risk and create violence-focused treatment plans accordingly? So as a result, I and so many of my other esteemed colleagues like David O'Brien, Sarah Weiniger-Budge, Jim Marley, Jamie Barrett, Rachel Nielsen, Matt Talbot, Ron Schouten, Qaida Hassan, these are all colleagues who planted the seeds for their work in part through conversations at the summit. We've come together to develop tools to help mental health professionals assess and manage risk of targeted violence, to develop and disseminate training curriculums in partnership with key professional associations like the American Psychological Association, to teach mental health professionals how to identify who on their caseload may be at risk and then what can be done about it, and developing practitioner networks to ensure that colleagues are consulting with and learning from each other in what is still a very nascent field. In several working groups over the next few days, including the Health Systems Working Group taking place tomorrow afternoon, we'll be discussing this work and continuing to refine these deliverables to produce the greatest possible impact. Please join us in these discussions. We want to hear from you. Whether or not you are a mental health professional, we want to hear from you. This will all help us move the field forward to ensure that people in need don't keep falling through the cracks.